Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
My guest today is Dr. Chris Meletis. Dr. Chris Meletis is an educator, international author, and lecturer. His personal mission is changing America's health one person at a time. Dr. Meletis has authored 19 books and over 200 national scientific articles in journals including Natural Health, Alternative and Complementary Therapies, The Townsend Letter for Doctors and Patients, Life Extension, and Natural Pharmacy. Dr. Meletis served as Dean of Naturopathic Medicine and the Chief Medical Officer for 7 years at the National College of Naturopathic Medicine, which is now the National University of Natural Medicine. He was awarded the 2003 Physician of the Year award by the American Association of Naturopathic Physicians. Dr. Meletis has a deep passion for helping the underprivileged and spearheaded the creation of 16 free natural medicine healthcare clinics in Portland, Oregon. Dr. Meletis and I discuss in this week's episode the relationship of nitric oxide and sleep apnea. We discuss melatonin and some other very interesting things that I think will help you get a little sleepier. So please join our conversation with Dr. Chris Meletis.
Well, good morning to you. I have Dr. Chris Meletis, and we're going to talk about nitric oxide and sleep apnea and maybe some other cool things, whatever comes up. Dr. Meletis, can you tell us how you got to where you are today and give the audience a little bit of background?
Well, certainly. It's a long journey. It all started with my father coming to the United States and wanting to start an exciting life. He ended up having me, and he worked as a laborer, super smart laborer, but he wanted a doctor as a son. So I went off to conventional medical school after going to Reed College, did 2 years in MD school, took my one class in nutrition between 88 and 90, and asked my professor at the time that I was teaching the class, which was intended as an underwater basket weaving class. It was supposed to be the easy class, but for me, it was a pivot because during that same time, I was in biochemistry class, physiology class, and I'm saying, we're talking B3 in nutrition class. We were talking about pellagra. We were talking about nicotinic receptors in pharmacology class. We were talking about NAD in biochemistry class. I'm going, but they're all interwoven. So I asked my nutrition professor, couldn't I just do an intervention clinically with a B3? He said, yeah, if you want to lose your license. This was back in 88, 90, right? Before nutrition was accepted as a potential clinical therapeutic. So came back. My sister was dating this guy that double dared me to become a naturopathic doctor. I became a naturopathic doctor, left MDdom, and here I am.
Okay. And I understood you served as the dean of the Naturopathic College out in Portland for a while.
Yeah, so I was the dean for 7 years. So I proudly announced to everybody I was institutionalized for 7 years. And probably for taking that position, I should have been institutionalized. So I started with hair and I left with no hair.
Okay. Well, you save on shampoo.
Yeah, hey, the shampoo and drying time, no hair dryer for me.
Right. So we're going to talk about nitric oxide today and fascinating molecule and sleep apnea. So why don't you give me a take on your perspective of how the interaction of sleep apnea, basically, we know it's associated with all types of comorbidities, cardiovascular disease, development of neurocognitive problems. Basically, I talked a week or so ago about how, sleep is really one of the four cornerstones of health. And the role it plays really in so many different things. But I from my research and understanding of nitric oxide, it seems that sleep apnea, the cardiovascular damage, the neurocognitive damage might be coming primarily from the reduction in nitric oxide due to the sleep apnea itself. So that is that erroneous, considering that maybe nitric oxide is the mediator of some of the detriment that is caused by obstructive sleep apnea?
No, you're right on the money. And if you think about, and I always translate things into how do I explain to my patients.
Right.
And so if you think of a garden, our trillions of cells of our human body are 60,000 miles of blood vessels and our 18,000 miles of capillaries going down to our distal aspect of, see how our circulation is, for example. And so if we think about a garden hose and we have a kink in the garden hose, our irrigation of our garden is not going to be so good. So nitric oxide, of course, is vasodilatory. Of course, in 1998, it got the Nobel Prize awarded to 3 individuals for this amazing gas our body makes every day, diminishes with time. And so by the age of 40, we're about half of where we used to be on our ability on a good day without apnea to offer perfusion. I happen to have had apnea when I was the dean at the Naturopathic University. I was thin, but I was like, I just don't feel very well. I was walking through a grocery store, doing the run through a grocery store to get home, and there's a couple things that the wife wanted. And I said, I just don't feel well. So I sat in the little pharmacy and the little grocery store. I took my blood pressures, 210 over 120.
Wow.
And I was maybe $185 at the time, 6'1". And it's like, And I was wondering what was going on. And at that same time, I decided I was going to start working out because I'm so out of shape. So I decided to do a whole lot of curls right before I went to bed. The next morning, I could barely extend my arm. And lo and behold, I didn't know it at the time, but I actually had created a bifart, like a myocardial infarction of my bicep. And so, and my liver enzymes, which are also enzymes for muscle damage, went to 400. And those of you on the audience that know, a normal liver enzyme, AST, ALT, is maybe like 30 or 20, but mine were 400. Okay. And so I was a hot mess. I had clearly damaged my nitric oxide pathway. My sleep was fractured terribly, and I was dying. And we know 38,000 people a year die of sleep apnea in the United States.
Wow.
They just don't wake up. And if you think about our relatives, grandpa and our uncle, like so-and-so, they died in their sleep. Well, why did they die in their sleep? Lots of reasons, but of course, apnea can be one of them. So the moment we go hypoxic and we don't have that vasodilatory effect, we have a problem. But our conversation will be so much broader than just apnea, because with the apnea comes our sympathetic tone. So apnea, what is it? It's auto-suffocation. So if someone came up behind us and started choking us, what does our adrenaline and noradrenaline do? We start clamping down, vasoconstricting. Those of us that have done surgeries, no, you put a little epi in with that lidocaine to prevent bleeding, right?
Right.
And so it's like, but now if you do that to your whole body, well, what's getting perfused? So now we have the sympathetic side of things, which is part of the nitric oxide impact with apnea. So we got sympathetic, and then we don't have the vasodilatory. So we have very tightened down vascular system, leading to just poor perfusion of the brain and tissues in general. As we're sitting here, 20% of our oxygen is going to our brain. And it's like, wow, can you imagine if it doesn't? And that's why people fall asleep and get car accidents and so forth and so on. But even this lack of nitric oxide ties into even hypogonadism, because with that apnea, what don't we water? We don't water the variable aspects of our garden, our ovaries and our testicles. And as a result, we get premature gonadal failure. So the nitric oxide apnea side of things ties into the whole aspect of us as hormonal creatures, neurotransmitter aspects, and nitric oxide helps with sleep-wake cycle too. And I have 3 peer-reviewed journal articles I can share with you, and you can share with your audience, all talking about sleep-wake cycle, sympathetic drive. And it's like, thank goodness you're doing this research, because it's life-saving.
So you and I had talked about in our discussion a week or so ago about taping your mouth shut at night, as far as, what effects that has. And I think it's very interesting. There was a book that was written by a guy named James Nestor, who wrote the book Breathe, which I have gifted many times because it's, when you talk with your colleagues that are biohackers, and it always comes down to, well, what technology, what gadget were you able to get that provided the best return on your investment? And I always laugh and say the dollar roll of tape. And I've upgraded now. I'm using the $2 roll of kinesio tape, which I think works very well. But in James Nestor's book, which I highly recommend to the audience get, I mean, it's one thing that's so simple, and it takes really very little adjustment to integrate this in your day-to-day activity. It will feel uncomfortable maybe for the first couple of nights, but it's amazing how once you tape your mouth shut, it forces you to breathe through your nose, which is going to produce more nitric oxide, because mouth breathing doesn't create that, as we know. And so let's talk about that a little bit. And I think you hit on something that I think is very important, is hypertension. And in his book, they monitored their blood biomarkers and their blood pressures. And within several days of just packing their nose shut so that they had to just constantly mouth breathe, they became hypertensive.
And I fully believe that. And when I came across that research a couple of years ago, I intentionally, when I'm not talking really quickly, breathe through my nose. And it helps calm us. And if you think about any meditative or prayerful practice, you sit there and you breathe in through your nose. And it's important. And I think the taping of the mouth is great, unless you have a deviated septum or a blocked sinus passage. Then it's a bad combination, because that there's like a dead end or road construction. You can't go that way. But getting yourself to be able to breathe through your nose sufficiently, and then taping the mouth. I have an 84-year-old patient. She actually has apnea, and she actually tapes her mouth at night, because for her, she would use nasal pillows, and it'd all blow out her mouth. It'd be like, and my sound effect for her blowing through her mouth. And so breathing through your nose, it was intended. We know our sinuses are designed with moisture, as well as ability to trap bacteria. So inhaling right into your lungs, not very smart to start with. So taping your mouth, assuming you don't have obstructive deviated septum or something that prevents you from doing it efficiently, all day long. And I see it with my patients, great success.
Right. And it's such an inexpensive modality to implement.
Yeah.
I mean, hardly anything. So what happens with apnea as far as how nitric oxide is depleted? Obviously, there's some very complex biochemical pathways that go on with this. And you mentioned that when you're age 50, you're already not producing much. I read a statistic that by age 60, you're only producing about 15% of the nitric oxide. So we're already starting in, just from an aging standpoint, into this, let's call it the zone of nitric oxide impairment. And now you compound it with something like sleep apnea. So is it just because when they go into, a period of sleep apnea or obstruction, they're just it's not forming from a nasal standpoint? Or is there more to it than that?
There's more to it. There's actually brain structures like the pontine tegmentum that actually is involved with the sleep-wake cycle. And so whether it be sleep apnea or just as we're getting older, we're not sleeping as well. And I think most of us, I can speak for myself, as I've gotten older, sleep has been more elusive.
Right.
And so that we go to bed earlier, we wake up, fracture sleep, even if you don't have to get up at night to urinate. And so it's part of that's the nitric oxide. And by even taking out the apnea, which I want to definitely loop back into, but if you're now don't have a nitric oxide, you're not supporting the perfusion of your pineal gland. You're not making sufficient melatonin. You're not watering the garden. And so our brain and all of its magnificentness needs to have perfusion. And without perfusion, whether it be throughout the day without apnea and at night without apnea, We're not getting the nitric oxide to perfuse our pituitary, our hypothalamic pathways, and of course our pineal gland. So we have to water that garden. And as we get older, our carotids might not be as patent as they used to be. So nitric oxide is just a no-brainer to bring us as much within warranty as we can have. And then to throw on top of that, the moment we go sympathetic and we start creating adrenaline and noradrenaline, the game's over. I mean, now we're vasoconstricting. We don't have, with our aging process, as much vasodilatory nitric oxide. So we're constricting and we're not actually expanding. And then everything's starting to basically shrivel on the vine, from plums to prunes, grapes to raisins.
So if you look at the the literature from a like neurodegenerative diseases standpoint, everybody, talks about Alzheimer's, at the top of mind, but there's some very compelling evidence that sleep apnea plays a huge role in early onset neurocognitive disorders. I think a lot of that's probably mediated just by this nitric oxide pathway and its impairment.
Well, that and the pro-inflammatory side of things. So if we all of a sudden were to put a tourniquet around our index finger and it was not getting perfused properly, not only will it, of course, change colors, but in addition, eventually will become pro-inflammatory and become necrotic. So we have to water our garden. And I always give that garden example because we're trillions of cells. And we have, like I said, 60,000 miles of blood vessels. Our heart beats about 103,680 times a day. And everything, including our cardiovascular system, needs to have that perfusion of nitric oxide. But one of the ways in which I look at patients, because a lot of patients, when I ask them, do you have apnea? No, I don't. I don't snore. I don't startle awake. A lot of people don't startle awake with apnea. A lot of people don't snore with apnea. My wife actually has apnea. And I noted that, how when you have a bed partner and they're like out of bed for a while, like, okay, I hope they're not sick in the bathroom or something. Well, she was laying there. I figured she had gone to the bathroom or something. She was laying there next to me, but I didn't sense her. So I rolled over and I said, I can't hear her breathing. And then I'm saying, oh my goodness. And I started getting a little bit more scared. Then I saw her every once in a while, her chest would move. Never once has my wife snored, but she was going down to 77% oxygen at night.
Oh, yeah.
And so I tell everybody, get a home sleep study. And these days, even as healthcare providers or as consumers, you can order one yourself online for about $100 to $250. It's reviewed by sleep medicine doctors. So if you have a big deductible or whatever, just go through that process of getting tested, because we all talk about the hierarchy of what's important in our lives. So we all talk food, eat well. Okay, yeah, given. It's a no-brainer. And then we go to stay hydrated. Yeah, that's important. And if you think we can live weeks without food, most of us, we can live a few days without moisture, but how long can we live without breathing? And so we take it for granted that we're breathing well at night and that we're not hypoxic, and so many diseases occur. But one of the things that also occurs with dramatic sleep apnea is shiny shin syndrome, which you probably know a lot about, peripheral artery disease. And it's like, so why have I lost the hair on my legs? Or why is my shin shiny and a little atrophic in terms of the skin layer? And that's because, once again, distal to the heart, and we're not, of course, perfusing. So that's an extreme case of apnea. And in my case, when I found out I had apnea, I was going down to 65% oxygen. And yes, I snored. And mine was dramatic, but I had lost all the hair on my shins. TMI for the audience, but hey, if I was to take a picture, I got my hair back. Some plates, just not in my head.
Right.
So I use a lot of humor with my patients, and I irritate my kids because I call it, they say, okay, enough dad jokes.
Right. So. Well, in Texas, the shiny skin down on the legs could be indicative of them just wearing a cowboy boot. So you have to do a little bit more,
yes.
And so I guess that's dependent upon where you are practicing. But you made a great point about monitoring. And I've been really enamored with biohacking and metrics. And one of the things that I found extremely useful is the Aura Ring. And
yes.
Particularly their generation 3, because it will measure your O2 saturation throughout the night, and it will tell you how many episodes you had throughout the night, it's a very powerful. Now, it's not as robust as the sleep study that you recommended, but I would think that the combination of the two would help people quite a bit. And then you can relate that to how much time you've spent in your different like REM versus deep sleep, and then how much it affects your heart rate variability. We're talking about sympathetic versus parasympathetic tone. And you can really get a lot of data from the simple thing, like just the Aura ring that I have on right now. So, I would, if anybody in the audience doesn't have an Aura ring, I would strongly recommend it. They're not very expensive, and the data that they give you is pretty tremendous. But
and I would echo that.
Yeah.
I have practiced in Oregon for 30 years. I have a large high-tech group of patients, and I learn a lot about technology and applying technology, and something so simple that gives you so much data. And if we look at the word restoration or restoring our body, trying to be kind to it, healthy agement, the word restoration or restore, first four letters are rest, R-E-S-T.
Right.
So we're not getting a quality sleep. And as I tell my patients, if you're not dreaming at least twice a week where you can recall it, not in a deep Jungian or Freudian analysis perspective, like, oh, I had an interesting dream, you're actually not getting to that sleep quality, and also possibly you're low on a B vitamin like B6. So once again, our body and our sleep is so important. We take it for granted until we can't sleep well, and then we don't take it for granted at all. We're like, oh my goodness, what can I do for sleep? And then people drug themselves to sleep, whether it be the over-the-counter diphenhydramine, the NyQuil kind of products out there, or they go for a prescription sleep med. And that actually also accelerates the potential risk for dementia, whereas nitric oxide has been shown to also help with the sleep-wake cycle through the in-neuronal aspects of the nitric oxide synthase. So we have, of course, the endothelial side of things, which is where sleep apnea impacts. We have the NON or NOS, and that's where the sleep-wake cycle comes into play. So by having robust levels of nitric oxide, when we go to bed, we're going to actually have a better sleep cycle there too. And then if you think about it, all of our heart rates, and you know this from your Aura ring, they go down. We slow our heart rates down dramatically. And I've had 3 or 4 sleep apnea tests, and I'll run normally around 60 or 70 heart rate throughout the day sitting, but I'll go down to 48 or 50. So now the heart's pumping slower, less frequently. And if it's going against either auto suffocation or peripheral resistance because of that sympathetic drive, we're going to end up with problems. And so once again, nitric oxide before bed, I think, is potentially life-saving. You, of course, do it during the day as well, but most people will wake up Monday morning stressed out. That's why there's more heart attacks Monday morning. And we also wish our life away because we say TGIF. Thank goodness, thank God it's Friday.
Right.
But we need to be supporting our body so that we can tackle things, but also from a nutritional perspective, let's just say someone's taking melatonin, or someone's taking 5-HTP for sleep, or GABA, or L-theanine to help support their sleep. Well, you have to deliver that to the brain. And so once again, you have to have the open highways and byways, and nitric oxide helps with that perfusion as well.
And, another little thing that a lot of people don't think about when they think about nitric oxide, they only think about vasodilation. And I think that's every practitioner is very well aware of how cardioprotective nitric oxide supplementation is because of the vasodilation. But the other thing that a lot of people forget is that nitric oxide has to be bound to the hemoglobin in order to offload the oxygen. So the most efficient way that it can. And if you have a depletion of nitric oxide, you're not able to offload that oxygen. So it's kind of a double whammy, so to speak. You not only have the vasoconstriction, but now you've lost the ability to offload that oxygen from the heme and to get it to the tissues where it needs to go.
And as well put in, it's actually an important consideration that even our patients that might be on oxygen, either at night, they have COPD, or they have other conditions that require oxygen, just putting a person on oxygen, we'll see that their oxygen levels on a pulse oximetry is better, but it's actually, just as you said, the nitric oxide releasing the oxygen will actually release the oxygen in a very intellectually wise way to low hypoxic areas or high hypoxemia. So if all of a sudden you have peripheral artery disease or a neuropathy of your feet secondary to for circulation, the nitric oxide is going to improve the release of the oxygen to the foot or the lower limb or to the other part of the body. So it's actually offers selective delivery of that oxygen if they're on therapeutic oxygen or room oxygen. So it actually allows the tissues that need it to get it in a very selective fashion. So it's the infinite wisdom of the human body just keeps me in awe all the time.
Yeah, and I think that's illustrated, the offloading of oxygen from the hemoglobin molecule when you supplement with, a nitric oxide precursor is really demonstrated in exercise. You can measure exercise just like you measured your sleep. You know how far you can run before your heart rate gets up to a certain level. And then you supplement with nitric oxide right before the exercise event. And it's unbelievable how it increases the functional capacity of what you're able to do during that. This is, again, something that you can monitor very easily. So there's very definite, significant benefits with nitric oxide precursor supplementation.
And breathing through our nose while we're doing our exercises. But like something as simple as I'm going to walk a mile, and all of a sudden I'm walking a mile a little quicker, and it's like I'm not nearly as out of breath, or I'm going to billy goat it up a hill, and I don't have the lactic acid build up as much. So often are going from aerobic to anaerobic with exercise, because I'm right by the Nike campus, so I have some select patients there as well that are pushing the envelope. And so, of course, what we're going to do is we're going to not go hypoxic. We're not going to go anaerobic. We're not going to have the lactic acid build up as much. And on a weird random note from the peer review literature, lactic acid buildup also increases anxiety and angst at the sympathetic level. So it's not just I hurt, it's also for those who are susceptible, can actually make you feel a little bit more wound up as well.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. Well, folks, if you are over 40 and you are not using a supplement to augment nitric oxide production, you should really think that. This molecule is absolutely imperative to health, not to mention its cardio protection. If you have any question on nitric oxide, I suggest that you go back and listen to the Pod of Inquiry, Season 1, Episode 3, for my conversation with one of the world's experts, Dr. Nathan Bryan. I never miss a day of nitric oxide supplementation. That's how important I believe it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett, all lowercase, at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration, and I'm certain you will be pleased not only for yourself, but all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see every one of those patients will be nitric oxide deficient. When they see this result, they will want you to start them up immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates.
Yeah, you mentioned about nose breathing during exercise, and there's a book called The Oxygen Advantage, and I'm blanking on the gentleman's name. I believe he was from Ireland, McCown maybe, where he has worked with a lot of Olympic athletes, and that's really one of the hardest things about when you start to tape your mouth shut at night to sleep, but then you try to do that when you exercise. It when you first start, you feel like you're suffocating. And he had a very interesting clinical study with Olympic athletes, and I believe they were track and field, but I haven't looked at that book for quite a while, so I don't know exactly. But the point is that it really decreased when he started putting these athletes into this regimen where he would get them to nose breathe during their exercise. These world-class athletes dropped in performance 33% right off the bat. And it took them, a period of time, and I think it was about 2 to 3 months to get back up to their level before. But once they got through that readjustment period, they actually increased their capacity, and they improved from an athlete standpoint, whatever they were trying to do. And that says a lot, because it's a lot easier to take somebody that's pretty out of shape and improve their performance. But to take a world-class Olympian and increase their functional capacity, that's hard. I mean, because it's like taking a PGA golfer and taking a half a putt per 18 holes off. I mean, that doesn't sound like much, but it's a huge interval for that performing athlete.
Yeah, and it just shows that with so much of what we do in modern life, we're less aware, we're too busy, we're too frenetic, and we're just wolfing down our food, we're wolfing down our air, and just open the mouth and shove it down. It's like, no, we need to be mindful of that. Right. And I'm thinking of an athlete. He became an athlete. For his 50th birthday, he actually wanted to do a marathon. He had never ran a marathon. He came to my clinical practice. Family had been my patients for a good period of time. He says, for my 50th birthday, I'm going to do a marathon. He says, okay, well, there's no marathons here in Portland, Oregon right now. And he said, oh, no, I'm going to go to Colorado. So
nice.
First thing you're thinking about is, hey, let's add some altitude to the mix, right?
Right.
And then I said, what? And so I started chatting with him. I said, you want to see 51, right? I says, our highest mountains are about 11,000 feet in Oregon. I says, are you running around Mount Hood? And I said, no, I'm just doing sea level stuff here. And you're getting ready for Colorado, huh? And then he said, well, and actually, it's not a marathon. I'm doing an ultra marathon. And I'm going like, okay, there went a patient.
You're right.
And so lo and behold, he survived. He's doing well now. But we had to pump up his ability to make ATP, nitric oxide delivery, and try to get him conditioned to some level that he wasn't going to die trying. Yes. And so we actually had to work a lot with him for the few months that I had. And I did the same thing with a 50-some-year-old wife of a chiropractor that I go to. She was qualifying for marathons, just regular marathons, but she had hit her personal best on her marathon. So she wasn't qualifying yet for the Boston Marathon. This was during the COVID era when everything was locked down. And so we actually dialed in her ATP production and her nitric oxide production, and she made the personal best, which surprised her, and she qualified. Then the marathon was canceled, which of course, sucked for her, but she did get her personal best once we dialed her in at a higher level, because she's one of those all-in patients. And I think the last one I would share is CrossFit training. A lot of people are really hardcore on CrossFit. I had a 36-year-old gentleman that CrossFit himself to the hospital because he actually got rhamnomyelitis because he went so anaerobic that his mitochondria started failing him. So we might hear rhamnomyelitis from, let's say, taking a statin drug or other medications, but he went hypoxic. So once again, I had to work with him, and he had a deviated septum on top of it. So this was before he was my patient, but now we helped him not go to the hospital again. And an Adonis of a fellow, I mean, working on from a 6 to an 8 pack, I mean, just totally shredded and ripped, but he went beyond his aerobic capacity that far.
Right. Well, exercise is a drug, and it has to be dosed properly. And, so there's that therapeutic window. But unfortunately, sometimes when you get taking that drug and you start exercising, it's real hard to take those recovery days and not do crazy stuff where you just break yourself down. Now, you mentioned something that I want to get a little bit into with sleep, and that's melatonin, because people will always ask, well, should I supplement it? And if I do supplement it, how much should I supplement it? When should I supplement it? And I will disclose that I know very little about melatonin, except that it has a lot more functions than maybe just the sleep-wake cycle. And so let's talk about that if you could for a little bit.
So once again, back to the nitric oxide and the thing that we all know about the vasodilatory side of things, but also because it is a signaling molecule in our body. It even has a neurotransmitter signaling capacity as well. But the pineal gland, as we get older, especially if we've had lots of fluoride in our water, it starts becoming calcified. And it just also becomes old like many other parts of our body. So it's not producing the melatonin. So nitric oxide levels are dropping, ATP levels are dropping, and melatonin levels are dropping with age. The highest levels of melatonin we have is when we're babies, and babies sleep like babies sleep.
Right.
Sleep like a baby, right?
Right.
And then once we get right around the teenage years, we start becoming night owls. We want to stay up later. And that's our melatonin levels are starting to crest and starting to diminish. And then it just a downhill slope from there. But melatonin is an antioxidant. Melatonin also came out in the peer-reviewed literature during the COVID era as something that helped with cytokines, inflammatory processes. And we know that if you go to PubMed and type in melatonin cytokines, you'll find what you'll find. And it's intriguing to think, okay, this is a molecule. We've always just like nitric oxide. Well, that's a vasodilatory molecule. No, it's so much more. And so melatonin, oh, that's a sleep molecule. So much more. Antioxidant, anti-inflammatory. My sister's right now dealing with metastatic breast cancer. She's applying it to that therapeutic as well, and making no claims. I'm just telling you what I recommended for my sister and why, and send her to the peer review literature because she's a researcher. She's not a healthcare provider, but she's a researcher. So I'm always going to be a big brother, but she's going to, okay, well, can you show me the literature that says that? Like, okay, here it is. And so as a result, melatonin helps with the inflammatory side of things, the antioxidant side of things, of course, sleep quality. And so I take myself 10 milligrams a night. I have her on 20 milligrams a night. And one of the big things in the controversies in the healthcare community is, are we suppressing our pineal gland from making melatonin when we take high doses of melatonin? And there's a lot of controversy, a lot of opinions, and lots of vim and vigor about it. But unlike the pituitary gland and the hypothalamic pathway, if we gave a lot of steroid, we're shutting down ACTH. If we give a lot of exogenous testosterone, we're shutting down LH and FSH, the same thing with estradiol or progesterone. It doesn't seem to have the same cycle and feedback loop. And as I share with all my patients and all the colleagues that I go around the country lecturing with, we're trying to make ourselves physiological, not super physiological, but physiological. So we know we're short on nitric oxide. So everybody is short on nitric oxide from an aging perspective, unless they're a rare genetic anomaly. So same thing with melatonin. It drops with age. So it only makes sense from functional medicine perspective to replace the things that are diminishing with the age. So ATP production, so mitochondrial function. We also know that some other pathways, the sirtuin pathway becomes diminished, the PARPs pathway, the CD38, fancy words, but all this is related to NAD levels. And the NAD levels are dropping along with the nitric oxide. So I like to replace the levels to a youthful level, to level the playing field, and basically try to bring us back into warranty. But if we don't have the building blocks, we can't build the house out of sticks, straw, or bricks, like the three little pigs. We don't have the building blocks. We don't have the substrate. We don't have the energy to do it, or the perfusion.
Now, is there an ideal time for administration of melatonin?
If you're just using it for sleep, I like to use it about an hour to 90 minutes to an hour before sleep.
Okay.
There are sublingual lozenges, which are instant release. So they can be half an hour before sleep. And then there's sustained release lozenges, or sustained release pills that you can take, that for those of us that wake up at 4 or 5 and we really want to sleep to 6 or 7 or 8, you can actually dose yourself with the regular capsule, 3 milligrams, whatever you would choose. And then I take that 60 to 90 minutes before sleep. Or a lozenge if you're trying to get to sleep and need that push into sleep. And then the sustained release to keep you asleep. So you can kind of dose it accordingly. And so the beauty of this is using technology, the regular capsule, the time release, or the instant release.
So you're talking, and we're not giving dosages out here. That's not the premise of the podcast. So, but just from informational purposes, we're talking 10 milligrams down to 3 milligrams. Is that considered a low dose?
Low dose would be 1 milligram.
1 milligram?
Or 0.5. And so melatonin drops are popular as well. And once again, as always, as you just point out, not prescribing, not diagnosing, always go low and start slow. There's no reason to overdose, but staying within the physiological. So some of my patients will just start with drops. So drops are very divisible. And so they'll
Right.
start with one drop under their tongue 30 minutes before bed, and hey, that did the trick. Well, then why do more? Unless
Right.
you're going for some other benefit like cytokines or some immunological input. So 3 milligrams has been the end all be all for decades. But some patients need less. They just need the nudge. And then you throw on, well, how good are they sleeping anyway with the nose breathing, mouth breathing, apnea? So you have to individualize dosing as always to the case at hand. But start low and you can always nudge up. In fact, the call right before we were doing our podcast today was on a young girl, and her neurotransmitter tests were all diminutive. Barely anything showing up on a neurotransmitter test that we did for her, which was urinary. And I'm saying she has a developing brain, and we're actually going to start a very low dose, and we're going to nudge her because what we're trying to do is teach the body to fish, not to give it a fish. We're trying to encourage it. So back to your nose breathing. Let's breathe through our nose. Let's increase our nitric oxide levels. But knowing that as we get older, arginine that pathway doesn't work as well. And so this is why we want to supplement with nitric oxide substrates, and ones ideally that don't have oxalates in them, like beets or spinach, something more like with an arugula, low oxalate food. And so we want to support those levels because once again, you have to have the ability to make the nitric oxide. So you're breathing through your nose, but the substrates aren't there because we're not as good absorbers. We don't do as many things as well as we get older. So we supplement a good diet.
So it brings me to a couple of questions. One is the bioavailability of oral capsules of melatonin versus the drops or a sublingual administration. I would think that the sublingual would be more bioavailable than,
Yes.
Okay. So you may, if you were going to take a capsule, you may take a 10 milligram versus a 3 milligram sublingual dose or 1 milligram sublingual, or is that kind of not true?
It varies on the person's GI tract. Of course, it's all about digestion. We have a world of digestive issues in this country, including irregular bowels and people that are only eliminating themselves every 2 to 3 days or longer. So the question is, how good is the transit time? How healthy is their GI tract?
Right.
But typically a low dose of 3 milligrams does the trick for a vast majority of people. But you're right, just like with B12, you're doing it, or any supplement for that matter, you're doing a liquid form. You're not having to break down that capsule. Maybe a person is on a PPI, proton pump inhibitor.
Mhm.
Maybe they have low stomach acid, which also diminishes with AIDS often. And so by the moment you go to a liquid or a dissolvable tablet, you eliminate the GI effect of how messed up are we from here down.
Well, I think you make an important point there about proton pump inhibitors, because we know that if you're on a proton pump inhibitor, you're not going to be able to break down the nitrite in the gastric juices like you should. And you probably would need to, if you're going to do some type of precursor nitric oxide supplementation, you would want to do that then with some type of a lozenge or sublingual administration, because the PPI is just going to knock that out for you. So you're kind of wasting your money.
And that is a risk. Depends on how successful the PPI is and how high the dose it is.
Right.
But the capsules, what's the beauty is you can test, not guess. And I'm a big test, not guess kind of doc. So I'm if anything, I over test. But you can do a little nitric oxide strip, measure where your nitric oxide levels are, take the capsule or lozenge, but capsule, and then see what happens. Right. And you can see the needle move, much like the Oura ring you've been mentioning. Data is important. And for us that try to become as scientific as possible, knowing, okay, I've done this intervention and this has been the outcome, and my blood pressure is lower, and the strip is more bright pink or reddish hued. All these are good signs that you're at the dose you need. And so once again, nudging the body and teaching it to fish opposed to giving it a fish.
Now, the other question that I wanted to ask you, because you brought this up, was oxalates. And the literature seems to be pointing to high oxalate diets in, correlation, maybe not causation, with autistic disorders. And, that we know that oxalates are maybe not ideal from a neurocognitive standpoint. Can you comment on that a little bit?
Well, yeah, I can comment upon that. And also, of course, we know calcium oxalate stones And it's about 9% of women will somewhere in their life have a calcium oxalate stone, 11% of men will. And also vulvodynia, which is painful vulva,
Right.
is also oxalate related to some degree as well. They don't know whether it's caused by the oxalates or just irritated by the oxalates. So you want to avoid those things. But whether we have salicylates, oxalates, lectins, these non-nutritive substances, they're all potentially, they come with a burden to them.
Right.
And so what we want to do is try to avoid, we all took the Hippocratic Oath as providers, and we have to try to avoid becoming hypocritical. And
Right.
so whenever we even do natural things, we want to make it as pure and as clean as possible without the downside of potentially adding to a person's oxalate burden. So like with autism, we know there's so many considerations as to why and where. And I think the reason they haven't delineated what this magic thing or misfortunate thing caused this, there's many ways to the same problem. But if we were, for example, to speak about MTHF,
Right.
methylene tetrahydrofolate, and the enzyme methyl tetrahydrofolate reductase, if a person has with autism the methylene tetrahydrofolate reductase polymorphism, they're more likely to end up with a susceptibility to toxins, mercury, aluminum, environmental epigenetic burdens, including oxalates or salicylates for that matter, or glyphosate, Roundup.
Right. Right.
All of these things. So I think that's one reason they haven't found like, okay, well, every kid that takes a vaccine has a problem. No, that's not true.
Right.
Every kid that was introduced to this had no, because we all get to our journey, even ourselves, whether it be high blood pressure, a bum knee, or whatnot, as a result of the life journey. Well, I fell as a kid and stubbed my knee and fell off my bicycle and tweaked my meniscus. So as a result, guess what? Somebody else
Right.
has it for another reason because they're flat-footed or high arched or whatever.
So just one more thing on the oxalates. I think I recall that there is an association, again, not causation, more of a correlation with chronic depression and higher levels of oxalates. Am I recalling that correctly?
I'm also recalling it vaguely. Having written 19 books, I have all these little files in my head, but I know there's a long list of problems with oxalates, as well as they, of course, cause you to not absorb things like spinach high in oxalate. So you're not going to absorb the iron as well. But I don't know about the cognitive impact as relative to like a depression or anxiety, but it wouldn't surprise me.
Right.
I think this is why we're supposed to moderate our diets and not overburden ourselves with any given food, whether it be a histamine-rich food, a lectin-rich food, or something immunologically from an IgG, IgA, IgG4, IgE perspective. Just moderate our foods and listen to our bodies. We sit at our desk, we shovel it in, where some people are driving and they're eating, but we need to be mindful when we eat that we are fueling not only ourselves, but also our microbiome. And as you pointed out, the microbiome in the stomach acid is critical for making of nitric oxide and many other substrates, including butyrate, which of course allows us to absorb our nutrients. Because I have so many patients, I do lots of GI work in my clinical practice, and the butyrate levels are diminutive in the stool sample. And as a result, we know butyrate crosses over through the enterocytes and colonocytes down to the citric acid pathway that actually fuels the villi and the brush border enzymes and all of this, but also the production, of course, of nitric oxide and collagen and connective tissue. So I think, the balance point of not overdoing oxalates is important because there's a lot of potential downsides. And once again, moderation is the key.
Right. Well, I think that, and I've been preaching this, that we try to follow these really discrete biochemical pathways, but they're all interrelated. And, so it's nice from an academic standpoint to go down this tree and see what's happening here, but you have to realize that there's myriad other pathways that are affecting that pathway. And so I think it merits the consideration of what you just said, and that's having kind of for lack of a better term, a balanced diet rather than, well, I'm just going to eat grapefruit. That's it for the next 6 months. You see these weird diets in the literature, and you have to kind of step back for a minute and say, wait a second, what's really going on? That's not how ancestral humans lived.
applying a strong dose of common sense.
Yeah, right. Less of that every day here. So, Chris, anything else that you want to talk about? I know you've got kind of a time constraint, and I really appreciate your taking the time to come on. And we'll link those papers if you can forward them to me in the show notes, and put some links to one of the companies that you're working with that is producing a nitric oxide supplement that is oxalate free. Can I say oxalate free?
Mm-hmm.
Okay.
And I've lectured on nitric oxide over the years for many different companies. It's an area of passion of mine. My father died of a massive coronary event, and taking care of one's ticker, one's circulatory system. But I want to make sure the vitamins, minerals, and nutrients I take on a daily basis, along with my food, because once again, we call them supplements, not substitutes. They're bottles of supplements. We're supplementing our diets.
Right.
But I want to make sure they're getting to the target tissues. They're getting down to the mitochondria. They're getting down to where I need to do healing and repair. And so nitric oxide is a tool. When we age, it diminishes in our body systemically. And we know that per the peer review literature. And as you were mentioning, the oxalates and what we know and the milieu of biochemical pathways, over our careers together, we've seen that what we used to think has changed a lot, and the depth of science has increased dramatically. But I think since it took till 1998 that somebody got awarded a Nobel Prize for nitric oxide research, and we were really ignoring it until 1998. And I started my practice in 92. So I'm thinking from 92 to 98, and then it hit the clinical research in the mid 2000s. That's when I started lecturing about it. All these years, we could have been intervening and helping people with nitric oxide therapeutics, and we didn't even know they had really existed at a meaningful level, other than maybe in passing from one of our professors when we were in school. So applying our knowledge and continuing to learn. And I applaud you, Dr. Barrett, for sharing your knowledge and sharing the cutting edge research, because this is how we as clinicians get to learn more from one another. So you've done an amazing job. So thank you.
No, you brought up some great points, and I really appreciate your expertise. I'm going to probably have to bring you back, and we're going to have to talk more about some of the toxins, because we're so exposed to glyphosate, our fluoridated water, all of these things. I mean, we're constantly bombarded with all of these things that affect things like melatonin and affect nitric oxide. And so just by living, we're impairing ourselves on a day-to-day basis based on the environment that we're living in. And so I think we should, if you're willing to come back, and let's talk about some of the toxins and how we might mitigate that. And then you mentioned the gut microbiome, and I think that is a hugely important thing. They're saying now all things begin in the gut, and I don't have reason to doubt that. And
No, I would love to. And any topics that the audience would like to have us speak upon. My 19th book was on the mucosal milieu, which it talks about the skin, the blood, the brain. We were taught the blood-brain barrier was impermeable. Now we know that not to be the case. So once again, I'll finish with this thought. When I was part of an NIH grant, I was lecturing to fourth-year medical students, MD medical students, at the local medical school at Oregon Health Science University. And this school has been around since the 1800s. So we're sitting in an old auditorium, and I'm saying, you all know more than the people that sat in these chairs 5 years ago.
Right.
You have different therapeutics, you have different technology, you have different diagnostics. But remember, 5 years from now, as you sit on your laurels of knowing so much, you'll be dwarfed by the knowledge that is imparted 5 years from now. So being perpetual learners is our responsibility as clinicians.
Absolutely. We can become obsolete overnight.
Yes. More so these days than ever.
Yeah, exactly. All right. Well, Chris, thanks so much for coming on. I really appreciate you, and look forward to our next chat.
Thank you.
Based on the very positive and inquisitive feedback that I've received from my conversation with Dr. Robert Kornfeld, which was Season 2, Episode 4, which we discussed the integration of functional medicine into your podiatric medical practice, I wanted to share with you my personal experience and why you should really think about taking Dr. Kornfeld's excellent functional medicine course. Over 20 years ago, I quickly learned that we had to treat the whole patient, not just the symptom down in their lower extremity. but I did not have the luxury of being able to obtain something like Dr. Kornfeld's training course. I had to piece it all together, and truthfully, I am still piecing it together, as it is a constant and evolutionary process that will never end because new information is always becoming more and more available. But by taking his well-constructed course, you will have a strong foundation to continue that building upon. And oh yeah, maybe the best thing is that this will allow you to have the platform to launch out of the imprisonment of third-party insurance, which will improve your life. Think stress reduction here now, folks. And at the same time, you'll be able to optimize the lives of your patients. If you want to go from dysfunction to full function, start here right now. Functional medicine provides you with the powerful niche that will allow you to go into the direct pay model and be done with the insanity of participating with insurance. Go to his website now and tell him we sent you, because you don't want to be dysfunctional anymore. To get on board with this fantastic educational opportunity, go to Dr. Kornfeld's website, instituteforfunctionalpodiatricmedicine.com. That's instituteforfunctionalpodiatricmedicine.com.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, podofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.